Welcome to Unremarkable Labs. I have no idea what's being presented today, but I do know that Sankalp Aurora is going to present it. So Sankalp, why don't you introduce yourself?
Sure. Hi, my name is Sankalp Arora. I'm a second year internal medicine resident at UAB. I'm going to go into HEMONC, but this is not a HEMONC case.
And Julie?
I'm also a second year resident here at UAB, interested in infectious disease.
And the head of Unremarkable Labs now.
Hi everyone, I'm Natasha. I am also a second year resident, interested in general medicine.
They're actually almost third year residents. This is the end of the year. They're like third year residents. Well, go ahead and tell us the story, Sankalp.
Okay, so we have a 24-year-old male who comes to the clinic with complaints of abdominal pain, nausea, and vomiting for the past week.
Excuse me.
You want me to describe more, or you want to start asking questions?
So, and is that what time of the year is this?
So this is in the summer.
In the summer.
Yeah.
Because right now, where we're speaking, there's been a recent enterovirus quasi-epidemic. So this could be something infectious. 1 week of abdominal pain, nausea, and vomiting. You know, because it's Unremarkable Labs, you always think of diabetic ketoacidosis when you see abdominal pain, nausea, and vomiting. Could be a lot of things. We don't know who this guy is. We don't know what the abdominal pain's like, how much vomiting he has. So maybe you could give us those types of things, because those words need qualifiers.
Mm-hmm. So regarding the abdominal pain, it's periumbilical. In region-wise, it's around 6 on 10. It is non-radiating. In terms of the vomiting, it's non-bloody, non-bilious. It's been going on 4 to 5 times a day. Sometimes increases, sometimes lesser, but in the past week, it's been around, it's been like constant, basically. And let's see, yeah, and the nausea.
And does it awaken him from sleep?
It does not.
Is it, does eating stimulate it, or does he have vomiting without eating? And has this had an impact on his sleep, on his eating?
So the vomiting occurs irrespective of whether he eats or not. But yes, it has decreased his PO intake considerably.
Okay. So umbilical abdominal pain, non-radiating. Does anything make the pain better or worse?
Nothing really. It just comes and goes. He's come to the ED multiple times in the past for the same issue since the past 3 or 4 months.
So this is for the abdominal pain and the nausea and vomiting?
Yeah, it always presents together, and it sometimes just worsens. He goes to the ED, gets some nausea medication, comes back, feels a bit better, then again gets the same cycle started.
And any diarrhea or constipation? So
no diarrhea, no constipation.
Okay. So, I mean, there are all kinds of things that could be going on to cause these symptoms. We can put together a differential. I'm going to let Julian and Natasha, well, Natasha knows the case. So Julie, can you put together, what would be your differential at this point?
So I was with you, Dr. Centaur, when it was just a young person with a week of abdominal pain, nausea, vomiting. I was thinking more infectious, but then when we get the little tidbit that this is not the first time this has happened, and he's been having, intermittently these symptoms for the past 3 or 4 months, that changes my differential away from an acute infection. It still could be, more of the chronic infections, like sometimes Giardia can present like sort of indolently like this, but makes me think more, like go into more of the abdominal pain as far as thinking about structural things like, hernias, intussusception, things like that causing abdominal pain. And then more metabolic things, like you said, DKA. Some patients live right on the cusp in and out of DKA, or calcium, like hypercalcemia, things like that, that can be more systemic causes of abdominal pain.
And I was thinking about biliary tree. It's really unusual for a 24-year-old to have gallstones. But if you then tell me it's a 24-year-old who is SS positive and has sickle cell, then I'd say, oh yeah, that could definitely happen. So not knowing his past medical history, the pain doesn't sound severe enough for pancreatitis, although I guess it could be a type of pancreatitis. What would a 24-year-old get? Probably something like IgG4. Pancreatitis might be in the differential somewhere. We need to know if he's had previous abdominal surgeries, because that might help us. Interestingly, intussusception is pretty unusual in adults, but if for some reason he'd had a Roux-en-Y procedure, those can telescope and cause an intussusception. But we really don't know anything right now. There's so many things this could be that we're just showing that we know a lot of things that cause abdominal pain. But we don't really know what the abdominal pain is. So we probably need to know, is there anything else on review systems? Any B symptoms?
So yes, he has had decreased appetite, as I mentioned, because of the vomiting as well. He's also been complaining of fatigue and also has had a 5-pound weight loss in the past 6 months. In addition, he's also been feeling lightheaded, especially when he gets up from a sitting position. Other than that, negative for anything else.
And does he like hot showers?
He's been told by the ED to do that before, but it hasn't really helped him at all.
Okay, so that would make you think that somebody thought that perhaps this could be cannabinoid hyperemesis. Although I have seen some, they don't usually complain of abdominal pain. It's just the cyclical vomiting that they have. Although if you vomit enough, you get some abdominal pain. So do we have any past medical history on him? Any previous surgeries, any chronic diseases that we should know about?
So he has asthma, he has GERD. His chart has cannabis hyperemesis syndrome labeled, but we don't know if that's been truly diagnosed or what the story behind that is. No surgical histories, no family, like he doesn't know any significant family history of similar presentations. In terms of social history, he smokes 1 pack a day for the past 6 years. He's quit now a year. It's been a year since he quit. He does use cannabis significantly, at least like every night, but he's been trying to cut back down on it since he was told in the previous ED visits that it could possibly be causing some of his symptoms. Go ahead.
Has he noticed any skin changes and any tanning in places that you wouldn't normally tan?
Nothing really.
Okay. So I was thinking of Addison's might present like this. And so if he had Addison's, he might notice tanning. And medications that he's on right now?
So he takes albuterol PRN for his asthma and famotidine for his GERD. That's it.
Okay. Well, I have a feeling we're going to get to labs pretty soon. Let's go ahead and examine him before we get to the labs.
Okay, so looking at his vitals, he was afebrile, temp of 98.6. Blood pressure was 96/61 with a heart rate of 107. He was saturating 98% on room air and breathing 16 times a minute. In terms of exam, he was alert, resting in the bed in no acute distress. His breathing and heart sounds were fine. He was tachycardic, but otherwise regular rhythm. He did have positive orthostatic signs, like his orthostatic vitals were positive. Other than that, he did have some mild abdominal tenderness all over, but there was no guarding, no rigidity, negative Murphy's sign, and overall soft abdomen. In terms of his neurological exam was normal, skin was fine. Yeah, nothing else to note.
Yeah, so, well, I know what I'm going to do for him. I know I'm going to give him some fluids. Probably a metabolic panel is going to help us a whole lot. Because he's been vomiting so much, what are we going to expect, Julie?
So with vomiting, with prolonged vomiting, you can expect like the metabolic alkalosis. You can expect hypokalemia, hyponatremia. And you might see like a little bit of an AKI, like a pre-renal picture.
Yeah, and as a lot of people know, I don't like the term AKI until we've given them fluids and it comes back to normal. But his creatinine could be elevated. We probably would expect a BUN creatinine elevation, but might not get it because he hasn't been eating. So a lot of times with vomiting as a cause of volume contraction, you don't get that large BUN to creatinine ratio. We're expecting a large increase in the bicarb. What we don't know is whether he's going to have an anion gap. I mean, he could have an anion gap for several reasons. He could have ketosis just because he's not eating very much, or he could have diabetic ketoacidosis. He certainly could have lactic acidosis with that blood pressure and that pulse as a possibility. So we have to think about, we'll have to look at that real carefully and see what his anion gap is. I agree with you. I won't be surprised at all if he's hypokalemic. It'll be interesting to see if he might also be hypomagnesiemic. And I would always check phosphate in a guy like this. If he's not been eating and been vomiting, hypophosphatemia could be pretty dangerous. Whether he's hyponatremic or not, I doubt that that's going to be a large part of it, but I'm always surprised at times. I don't think we'll see very much on his CBC, although we might see an elevated white count just because he's under a lot of stress. We know that right now he's very, very much at danger of all of our stress diagnoses. So let's see what kind of numbers we got.
Okay, so starting with the metabolic panel, his sodium was 125, potassium was 4.5, chloride was 93, bicarb 17 with a gap of 15. Creatinine was 2.3. He has had a normal baseline historically. BUN was 40, glucose was 60, calcium of 10, magnesium of 1.3, and phos of 4. In terms of his CBC, his white count was 16, hemoglobin was 16, and platelets were 358.
So an elevated white count doesn't surprise us. So what do we think about this? Okay, if we calculate his anion gap, we're going to see that it's 15. Do we have an albumin on him?
Yeah, his albumin was 4.6.
4.6.
Mm-hmm.
So this is totally opposite of what we expected, right? We expected a high bicarb, and now we have a low bicarb. So that's really intriguing. We have a low sodium. So let's take this from low sodium. Does he have salt hunger?
Nothing that we could assess directly as such.
Why'd I ask that, Julie?
That would be part of a presentation of adrenal insufficiency.
Yeah. So what about this makes us worry about adrenal insufficiency?
So the orthostatic, I mean, he could be orthostatic just because he's volume down, but
right.
that would be one of the things that triggers me to think of that.
Mm-hmm.
And then we've got adrenal insufficiency, and Dr. Centaur, you know more about this than I do, but the metabolic acidosis with his potassium is a little on the higher end of normal, which I would not expect.
So it depends upon
right. So I would, with his vomiting, I would expect the potassium to be lower than it is.
Right. And so it depends upon whether he's just lost glucocorticoid or glucocorticoid and mineralocorticoid. If he's lost both, then that could explain the metabolic acidosis. And you could, it's technically a normal potassium, but it's on the high side. What do you want to do for him right now? When you first see him, what are you going to do to work him up?
Well, when I first see him, as you said, the first thing I would do is give him fluids. I'd probably give him a liter of LR.
Okay.
Um,
Would you do
and-
anything else?
I would probably get a VBG. And if I was thinking about adrenal insufficiency as much as we were, I'd get a random cortisol. I'd want to see how I respond to the fluids first before I went straight to steroids, I think.
Yeah, with that blood pressure, I probably would pull the trigger on which glucocorticoid. So when you admit them and you're not sure, but you don't want to mess up the cortisol stimulation test, which
So like
hmm?
be dexamethasone.
Yeah. So I think that because his blood pressure is low, because abdominal pain and nausea and vomiting can be a sign of Addison's, because we don't see the metabolic alkalosis we expect. We see too high of potassium, and we have significant hyponatremia. And when you go through the hyponatremia algorithm, before you do anything else, and we know he's volume contracted, that could be the reason, but before you do anything else, you rule out Addison's, you consider hypothyroidism, although that's controversial. You make sure they don't have chronic kidney disease. We don't believe this is chronic kidney disease. We believe this is volume contraction for right now. We'll get a urinalysis that may help us in trying to figure this out. I might order a urine sodium and urine potassium. So if in fact he's lost mineralocorticoid, then what we might see is a low urine potassium and a high urine sodium in the face of a potassium of 4.5. That might give us a clue that we're dealing with some kind of a type 4 RTA. And I'm really stretching that because it's not absolutely perfect, but I'm trying to figure out why he has a bicarb of 17. And with an albumin of 4.6, his anion gap is about what it should be. I can't say that's an increased anion gap. Now, I wouldn't blame anyone for getting a lactate, and we'll get a urinalysis and see whether he has ketones in it. What is a bit tricky here is that his white count's elevated, and we would expect his white count to be elevated if he had Cushing's, but you don't always get an elevated white count. It would be very interesting to look at a differential and see whether he has some eosinophilia, because you often see that with Addison's. By any chance, do you have a differential in that, Sankalp?
Yes, his neutrophils are 55%, lymphocytes were 30%, eosinophils were 3%, and monocytes were 10%.
Yeah. So I don't remember if that's elevated eosinophils, but they're certainly not absent. So one of my rules is, what is the most dangerous thing that I better not miss? And I think Julie and I are both wondered about that. And if Addison's is significantly in the differential, I'm giving some dexamethasone. I love getting a random cortisol, because the random cortisol is going to tell us whether or not to go down that path or not. And then we'd have to figure out why he has Addison's, if he does have Addison's, and we'll check some autoimmune studies. This could have nothing to do with that, but the surprising thing is that bicarb of 17. The bicarb of 17 is really hard to figure out. Are these numbers new for him? And when he came in before, when was the most recent time they drew labs on him in the emergency department?
A couple of months ago, when he was in the clinic for a less severe presentation, his creatinine was 0.9.
And what about his bicarb?
His bicarb was 22, I think, 22 or 23.
Okay. And so sodium and potassium were okay back then?
Mm-hmm. Yeah,
Okay.
This is new. The hyponatremia is new.
Okay. So I think things we do is we have to do a urinalysis. I love that Julie wants to give LR, and I think I'd give it fairly rapidly, given that blood pressure and that heart rate. I think that could be very useful. Now, the problem is if he's volume contracted, his sodium might go up too fast, but usually at 125, you're not putting the patient at risk. So if it was significantly lower than that, I'd be worried about raising it too fast. I'm not really worried at 125 that we're going to run into problems. So give us more information, Sankalp.
Awesome. Also, any other labs, any other imaging that you all wanted?
I want to do this first. I'm not sure that I need to do an abdominal series yet, but
Okay, so
if he was in the emergency department, they probably did.
yeah, so he did get a CT scan of his abdomen and pelvis with contrast, and there was no acute obstructive or inflammatory
Right.
process. So in terms of the labs though, so his UA did not have any ketones, did not have any evidence of infection. His specific gravity was 1.015.
Okay, so that's a little bit concentrated, so his kidneys are working. And we expected that with the BU and the creatinine ratio.
In terms of his, so his urine osmolarity was 434, and his urine sodium was 120, and his serum osmolarity was 266. All of them were drawn at the same time. Like the urine test and the serum test were done at the same time.
Yeah, so he's wasting salt, which happens fairly commonly in Addison's. He also is releasing ADH appropriately because he's volume contracted. That's the strongest stimulus for increased urinosms and increased ADH. I'm not worried about that at all. I don't think that's taking me anywhere. It's unlikely to be the syndrome of inappropriate ADH. This is probably appropriate ADH. And the pituitary releases ADH. The CT abdomen doesn't really show anything.
Yeah, it was negative.
Okay, so I think we're going down the right path. There's salt losing. We don't have, we don't have any evidence of any. I guess he could have pituitary problem, but usually you don't get mineralocorticoid with pituitary problem. We'd have to know where he's from. Could this be TB involving his adrenals? Could he have some kind of cancer involving his adrenals, or could this just be Addison's disease? Because some people do have some significant mineralocorticoid deficiency, and that has to be my leading diagnosis right now because of the acidosis in the face of all this vomiting. So did you give dexamethasone and get a random cortisol for us?
So we initially just first gave fluids, and it's because his pressures improved with the fluids, but his sodium did not improve much despite giving him the fluids. His sodium after like 2 liters of LR went from 125 to 127. We did get the morning cortisol, which was 0.5, and we did the ACTH stimulation test, which did not show any responses. Post-stimulation cortisol level was, I think, 1.5 or something. So very poor response. We checked his ACTH level next, and they were very elevated. They were 1,525, which is very high. Then we basically do further workup to figure out what the etiology was, because at this point we have established the diagnosis of primary adrenal insufficiency, and we can talk about why primary and not secondary, why after that. But
yeah, let's do that now. Let's do that now. I think that's important. So this is a beautiful workup. So the fact that he doesn't respond to ACTH with a significant increase in his cortisol tells us that his adrenals aren't making anything. So then the question is, this immunological cause for Addison's disease the most common cause, or is this he could have testicular cancer with metastases, but you already told us he had a CT of the abdomen and they didn't show anything, and the adrenals in both TB and cancer would give us a clue So we're going to do immunological tests. The fact that his ACTH level is very high is totally appropriate for someone who's not making cortisol. The pituitary is working as hard as it can to try to make cortisol come out. So it all makes sense. The question in treating this guy is going to be whether or not he's going to need both mineralocorticoid and glucocorticoid, because this looks like a type 4 RTA. Even though 4.5 is not technically elevated, it's relatively elevated. And if he's not making, if he's really hypoaldo, when you're hypoaldo, it would, if you had a urine potassium, it would be low in the face of a high urine potassium. And so this patient, I might try hydrocortisone first. And if that doesn't start to fix this, then we might have to add some 9-alpha-fludrocortisone, which most people know as Florinef, to give him the adrenal, the mineralocorticoid component. And he would be a good candidate for that. A lot of patients can't take that because they get significant hypertension from getting artificial aldosterone. That's really what fludrocortisone is. And so you have to be very careful in titrating that. I think that if you just give regular cortisol, it has some mineralocorticoid effect in it. And sometimes that's all you need to give, as opposed to giving prednisone. So it'd be interesting to see what endocrine said and whether or not the acid-base disorder improved when he got just cortisol alone, or did you have to add something else? Does that make sense, Julie?
Yes, it does.
So tell us what kind of test did you do to figure out? I assume it's autoimmune, and I never remember what autoimmune tests I have to get because I can look them up.
So actually, there are two common investigations that are sent when you're worried about autoimmune adrenal insufficiency. One of the obvious ones, anti-adrenal antibodies, unfortunately, is not very specific or sensitive, even though we got that and it was significantly positive. But ultimately, the diagnosis clincher is anti-21 hydroxylase antibodies, which are very specific. So if that's positive, then that's done. Your workup is done. In fact, like this case was in the ED, so they did a CT scan first. But if you look at the algorithm, if you're worried about Addison's or any adrenal insufficiency, you start off with these investigations. Right. And if anti-hydroxylase is negative, then you move on to CT scan and adrenal scans and whatnot. So in his case, it was positive, and that's how we diagnosed him with Addison's disease.
And
so,
and what about treatment? Did you have to add a mineralocorticoid?
So we actually started off with hydrocortisone for him. And so hydrocortisone has 1:1 glucocorticoid and mineralocorticoid activity. And that's why even for endocrine discussion, we don't really need fludrocortisone in an acute setting because hydrocortisone usually covers both of those aspects. Mm-hmm. When we discharged him with prednisone and fludrocortisone, because prednisone doesn't have as much as mineralocorticoid activity. And so in the US, we use hydrocortisone a lot. So that's why this is not an issue. But in other countries in the Europe where dexamethasone is the primary steroid of choice that they use, there you usually have to add fludrocortisone as an added agent if you have somebody with acute insufficiency coming up.
Right. And I assume his numbers all came back to normal once he probably felt better than he'd felt in 6 months.
Yeah, I think the biggest catch in his case was every time he came in, he was just being labeled as cannabis hyperemesis syndrome because he did have a big cannabis use history, and that's what comes to everybody's mind. But this was basically adrenal insufficiency hiding in plain sight. And luckily for him, the acute presentation was not that life-threatening, and we caught it early enough, but it could have been much more catastrophic if this kept on getting missed. And there were actually some, when we look at like primary versus secondary insufficiencies, I think hyponatremia can occur in both of them. But as you all mentioned, the fact that his potassium was 4.5, despite him being vomiting so much and being so dehydrated, that was a big clue that indicated that this was something primary.
Yeah, I have to correct you on one thing, Sandkalp. He was not dehydrated. He was volume contracted.
Sorry, volume contracted. Yeah.
There are a couple really interesting things about this. First is my illness script for cannabinoid hyperemesis is hot showers. And if he wasn't getting relief from hot showers, that would make me reconsider the diagnosis. And we said that before we knew the numbers. It just, everyone I've seen, several of the patients I've seen, every time you go in the room, they're taking a shower. It really is such a classic thing. So I would have to question the diagnosis for that. And if he was only smoking in the evenings, God, they usually smoke more than that when they have cannabinoid hyperemesis. So I think that's a diagnosis of exclusion after you've ruled other things out. I assume that they didn't get labs, that several times he came in and they didn't get labs. And I think labs can be really helpful. Someone's vomiting that much. Now, they clearly had to get labs this time, and the labs tell the story. Because it makes no sense that he has a bicarb of 17, and then you have to figure that out. And it's also sort of, a sodium of 125 in an otherwise healthy guy who's not keeping anything down. And then when you get the numbers, you see that he's really he's salt wasting, and he's holding on to water because his urine osms are up. And that's all very, very consistent with Addison's. So if you sit there and look at those numbers carefully and say, wait a second, how am I going to put all this together? I think that's why we got there so quickly. Now, it's a whole lot easier to get there quickly when someone presents you a case than when you actually go see the patient in the emergency department, because you've curated everything for us ahead of time. His eosinophils were his eosinophils were borderline, right?
Yeah.
Yeah, but still, but I still think it's sort of a clue.
Yeah, definitely. And yeah, I think, that was what I was going to say. But yeah, his sugar was also 60, which initially also ticked us off, even though he was not eating much, and there were other reasons for him to be hypoglycemic, but just adds another part of the illness script to Addison's disease. And
you're right. That glucose is it's technically normal, but it's borderline no. So let's see what the big learning points and this is a great case because the guy's doing well now. Because he made the diagnosis. I get very excited when you have to think hard to figure out what the patient has and the patient benefits. That makes me very happy. Did we lose Julie? We lost Julie for now. So Natasha, what were your big lessons from this case? And what do you want people watching to really take out of this?
So this is very general, but I think always question the diagnosis. It's really easy, as we were talking about, if you have a 24-year-old gentleman come in with vomiting, smokes marijuana in the ED, gets labeled as cannabinoid hyperemesis syndrome. But as you said, taking a good history can be very helpful, and the fact that he's not getting better with hot showers. So I think that was the biggest thing. And two, I think this case was a really good review of just like endocrine and renal physiology and thinking what the kidneys are doing and how they should be responding in a volume contracted state, and how his were not responding appropriately. So yeah, the other thing that was good review that I didn't realize that eosinophilia can be related with Addison's disease. And I just looked up while Sankalp was presenting that an absolute eosinophil count of greater than 500 is defined as eosinophilia. So that was a good little review because I hadn't thought of that in a while. I think a lot of really good learning points in this case, and not just labeling him also as a pre-renal AKI, seeing that he didn't necessarily improve with fluids.
Yes. So there are a couple things that, and I teach these a lot. If Addison's is in your differential, give them a dose of dexamethasone. It does not and get a random cortisol. And I've never heard of someone being criticized for giving dexamethasone. I might criticize you for giving hydrocortisone at night, because then that messes up the cortisone stimulation test. But I think that's a really important point. The fact that you got the cortisone stimulation test and the ACTH really nailing down the diagnosis. The fact they already did a CT scan, we wouldn't have done a CT scan on this guy. We had no reason to think of that. Mm-hmm. And once we got back the anti-21 hydroxylase antibodies, we wouldn't scan him, because that's very unusual. We had no reason to think of TB here. We really didn't have any reason to think of cancer involving the adrenal glands. I think it's important to remember that while classically Addison's is a glucocorticoid, there's also often mineralocorticoid involvement, and that to me, it seemed almost obvious once I saw that bicarb, that's what we'd have to be dealing with. And I think that the surprise of that, if I wasn't thinking before, that would make me think. Sandkamplis, your case, what did you get? And I know you've presented before. What did you get out of this discussion that will help you in the future?
I think, as Natasha mentioned, the hypereosinophilia part of it, even though we know that like steroid deficiency can cause hypereosinophilia, we don't, like, I never at least associated that with Addison's before. So that is good to know. And then in general, like the typical workup, looking at the type 4 RTA as an etiology, looking at the fact that you could give dexamethasone before itself and it won't interfere with your ACTH stimulation test next morning. That's a great learning point as well, because our concern was that giving steroids at that point would have affected the test next day. We didn't think of dexamethasone at that point. So I think that's also a great learning point. And one thing which I learned while after doing this workup was looking at how to interpret cortisol levels. I know we talked about random cortisol. The only caveat to that is it's only useful if it's more than 14.6. Mm-hmm. You can have, because cortisol has diurnal variation, even if you get a random cortisol of 0.5 or 1 in the evening or in the middle of the night, it's not going to help me make the diagnosis or break the diagnosis. So I think it's in that standpoint, the ACTH stimulation test really works out. So all of these, interpreting how these labs work, how random cortisol works, really, that was something I was not very confident of before, but I learned through this case.
I think if the random cortisol was 10 or 12, you pretty much will have ruled out Addison's. If it's high enough, so it's good for a rule out, it's not good for a rule in. Mm-hmm. And I think that's important to know. Mm-hmm. But really, really beautiful, clean case that hopefully everybody's going to learn a lot from. Thank you so much for presenting it.
No problem. Thank you so much.
Thank you, guys.